Hello everyone. Thanks for joining in and coming on to my channel. I would be discussing this topic today, mitochondrial encephalopathy with lactic acidosis and stroke-like episodes, MELAS syndrome. I did a little review on this topic. Just a little introduction about myself. I'm currently a stroke fellow working at the University of Calgary stroke program. Um, and I will be going through the different aspects of MELAS syndrome with you guys in the next few minutes. I have no disclosures and we're gonna straightly go to the presentation. So, MELAS syndrome was one of the most frequent maternally inherited disorder, which was defined back in 1984 by Pavlakis et al. The three cardinal features in this disorder were mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. This was the first historical paper from 1984 by Pavlakis et al. And his team. Mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episodes are distinctive clinical syndrome. In this case report, they reported two patients who had mitochondrial myopathy, encephalopathy, lactic acidosis, and recurrent cerebral insults that resembled MELAS. These two, and in the literature and in their whole case series, they did a retrospective analysis of previously reported cases which resembled their patients, and totally they defined around nine previous patients which were already having features which were similar to their cases. So in these two reported patients, their common theme was that there were ragged red fibers evident on muscle biopsy, normal early development, short stature, seizures, hemiparesis, hemianopia, or cortical blindness. Their serums revealed lactic acidemia, which was a common finding. They believed that MELAS represented a distinctive syndrome and that it can be differentiated from two other clinical disorders that also are associated with mitochondrial myopathy and cerebral disease at that time. One was the Keene-Sayer syndrome and the myoclonic epilepsy, ragged red fiber syndrome, or commonly called as MRF. So existing information suggested at that time that MELAS is transmitted by the maternal inheritance. Ragged red fiber suggested an abnormality of the electron transport system, but the precise biochemical disorder in these three clinical syndrome remained unknown at that time. To further elucidate what they reported in this case series, this was the patient one, which they described in 1984. A boy who had a normal prenatal and a perinatal history. Just polydactyly was noted at birth. At 3 years of age, there was some delayed motor language development problems. School performance was slightly below average for his peer group. At the age of 8 years, there was a concern about short stature. Sensory neural hearing loss was noted at around 14 years. Um, his one sibling was unaffected and the family history was normal. Otherwise, until the age of 15 years, he had two generalized tonic-clonic seizures that lasted 10 minutes with residual left arm and hand weakness and sensory loss. These abnormalities partially resolved within 4 weeks. Uh, if you can appreciate on the right side, this is the CT scan findings from the image back then in the time. It's pretty outdated looking, and there was possibly at that time the technology of their era. So the CT demonstrated a small right frontoparietal lucency. At age 16, he was again admitted to a hospital after sudden onset of right hand weakness and aggressive behavior and confusion. There were expressive aphasia and right-sided hemiparesis. CSF done was normal except for a protein concentration that was noted to be 76 milligram per deciliter. A CT showed bilateral non-enhancing parietal lucencies. Cerebral angiography with magnification views showed no abnormalities of the vessels. The boy was treated with phenytoin and 2-week course of prednisolone in their case report, which later resolved his problems and symptoms. This is the table of the retrospective analysis which they conducted in the same paper, and you can see there are 9 prior patients before there are 2 patients. So I would briefly go through the clinical features and the laboratory features of each case. There is a common theme in all these cases, but there are different phenotypical clinical manifestations which can be seen in this table. So the first case was from a paper back in 1976 of a 6-year-old girl with periodic loss of consciousness, dementia, hearing loss, transient right-sided hemiparesis who died at 9 years. Her ECG showed flat T waves, creatinine kinase, and LDH levels which were elevated. Muscle carnitine was decreased. The second case was of a 9-year-old boy with deteriorating school performance, focal seizures, alternating hemiparesis, episodic vomiting. His lab studies showed basal ganglia calcifications, slow sensory conduction velocities, blunted growth hormone responses to insulin-induced hypoglycemia. Third case was of a 9-year-old boy with episodic vomiting, focal seizures, alternating hemiparesis, single episode of blindness. Fourth case was of an 11-year-old boy with left-sided homonymous heminopia following right-sided headache. He had alexia without agraphia. Basal ganglia calcifications were also noted in him. Bilateral parieto-occipital lucencies with an elevated liver function enzymes. The fifth case was of an 18-year-old woman with episodic vomiting, headache, left visual field cut, and hemiparesis, cortical blindness, and dementia. The lab studies showed alteration of cerebral cortex, microcystic liquefaction, basal ganglia mineralization that were noted on her postmortem finding. Sixth case was of a 16-year-old brother of patient number 5 with limited extraocular motility and progressive encephalopathy, no stroke-like syndrome. Seventh was a case of a 16-year-old girl with episodic vomiting and ataxia, left visual field cut, and hemiparesis, deafness, myoclonic seizures, progressive encephalopathy. ECG showed flattened T waves, focal microcytic softening of cerebrum, and basal ganglia mineralization noted at postmortem. Eighth case was of a 10-year-old brother of patient 7 who had episodic vomiting, right hemiparesis, blindness, myoclonic seizures, progressive encephalopathy. The findings were elevated creatinine kinase, LDH, and postmortem findings similar to those of sister. Muscle was not examined in this case. Ninth case was of a 12-year-old boy with episodic vomiting, similarly, blindness, progressive encephalopathy, and coma, with focal lucencies on the CT scan. 10th case was the patient 1, which I previously described, of the 16-year-old boy. with alternating hemiparesis, aphasia, decreased hearing, progressive encephalopathy. Bilateral parietal lucencies were noted on the CT scan with a normal CT angiogram. The second case, which was reported in the same paper, was of a 13-year-old boy with episodic vomiting, alternating hemiparesis, blindness, progressive encephalopathy, and bilateral occipital right-sided parietal and basal ganglia lucencies. So these were at the time puzzling cases before they coined this term MELAS, and that was distinctively characterized from its cousins, which were Kearns-Sayre syndrome at the time and MRF, due to these stroke-like episodes and some maternal mode of inheritance and these other features. So coming to the mitochondrial disorders, what is mitochondria? Mitochondria is the only double membrane organelle that is found in the human body, in the human cell. Uh, it is present in all nucleated human cells and performs a variety of essential functions, most importantly generating cellular energy via oxidative phosphorylation. The inner membranes have these granules, ribosomes, cristae, inner membrane space matrix, and ATPase synthesizing units or complexes which are embedded in the inner membrane. This is the oxidative phosphorylation, the process. This is the simplistic diagram of an electron transport chain. What happens is that there are these complexes which are numbered from 1 to 5, and there's a potential gradient between their electronic charge from complex 1 to complex 5. There is this potential gradient due to which these electrons move towards the right at two steps. In step 2 there is a catalysm which is due to coenzyme Q10, and between 3 and 4 complex there is also a catalyst which is required called cytochrome C. At the last step, complex 5, it generates the cellular energy by catalyzing the process between ADP and phosphate and generating ATP. Uh, Coming to the mitochondrial pathogenesis, the oxidative phosphorylation system consists of almost 85 subunits and is actually under the control of two genomes, the nuclear DNA and the mitochondrial DNA. So the two genomes within the oxidative phosphorylation system has components which are assembled by these two different genomes, one coming from the nucleus of the cell and one indigenous to the mitochondria. The mitochondrial diseases can arise due to the pathogenic variants in either of these two genomes, either the nuclear DNA or the mitochondrial DNA. The genetic complexity and the multiple biochemical functions of these organelles, specifically mitochondrial DNAs, are phenotypically and genetically heterogeneous. There are rules to the mitochondrial pathogenesis of mitochondrial disorders. The two important concepts to grasp here are maternal mode of inheritance. Maternal mode of inheritance is an interesting concept because all these mitochondria, they have the genetic material, the mitochondrial DNA, which comes from only the mother. And that is one of the reasons why we can trace back the mitochondrial DNA and the mitochondrial inheritance in a maternal fashion. And scientists call this as the first Eve concept, where you can trace back your maternal DNA back to the first female. Heteroplasmy is a concept different from other genetic disorders where it is more of a quantitative concept, because there is wild type DNA which is not mutated in the mitochondria and the mutant type DNA, and the degree of severity of the clinical manifestation is dependent upon how much of the percentage of this mutant DNA mitochondria carry, and how impaired is the mitochondrial function due to this buildup of the mutant type DNA within the mitochondria. This is a schematic diagram just to simplify. If the father has the disease, then the children will not have the disease because the fathers are not able to transmit their mitochondrial DNA to their children. The reason for this is an autophagocytic process which happens in the father's mitochondrial DNA, and it self-destructs itself at the time of cell division and when during mitosis and meiosis phases. Mothers with the disease who have all mitochondria which are mutant, then they have a possibility of passing the disease to all their children, assuming that a complete penetrance is achieved. Mothers with the disease with some mitochondria which is normal, other which is mutant, can pass the disease to some children, and some children may have the disease and some may not have the disease, depending upon how much their DNA is affected. From a point of view of MELAS in particular and its pathogenesis, there is a specific gene loci, M3243, where there is an adenine base pair which is substituted with the guanine base pair. This is the most common position at the most commonly found mutation in MELAS, which is at MTL1 gene. Uh, this mutation causes the decreased mitochondrial protein synthesis, which impairs mitochondrial energy production. This in turn causes an increased mitochondrial proliferation and at the sites where there is higher hypermetabolism. Angiopathy and endothelial dysfunction ensues in these areas due to higher oxygen requirements and a lower energy production, which in turn causes impaired perfusion and at the microvascular level. The second mechanism due to which the impaired mitochondrial energy production plays its roles is through decreased production of citrulline and decreased production of arginine, which both are necessary for producing nitric oxide at the endothelial level. And as we know, nitric oxide is related with vasodilation at the endothelial level. When this mechanism is hampered, uh, there is a reduced availability of blood at the site. The third process which is hampered is an oxidative stress, which is brought up and about by reduced production of energy in mitochondria, which leads to free radical induced injury. All these three mechanisms can cause multi-organ dysfunction at various metabolic higher metabolic uh, structures and higher metabolic organelles, and causes the organ failure in general. Coming to the epidemiology of mitochondrial disorders, they are considered rare diseases, but among rare disorders, they are relatively frequent, with an overall estimated prevalence of 11.50 out of 100,000. The prevalence of the The prevalence of these mitochondrial disorders, there was a study which was done in Japan, and it showed a prevalence of 0.18 by 100,000 of MELAS within the mitochondrial disorders. They also describe two forms of the disease, juvenile form and the adult form, depending upon when was the disease onset. There was another interesting paper which looked at the epidemiology and the prevalence of the A3243 gene mutation uh, in MELAS, and they found the frequency of the mitochondrial DNA mutation in 16.3 out of 100,000 adult population. Clinical evaluation of these people who were carrying the mitochondrial DNA mutation found that they had hearing impairment, to some degree cognitive decline, and short stature. There was an interesting paper which was published in Neurology Genetics back in March 2020, and it showed that pathogenic variants in 666 patients who had a diagnosis which was made on the basis of their genetic test to have mitochondrial DNA variations or mutations in 414 participants, and 252 had the nuclear gene variant. MELAS was the second most common mitochondrial disorder after Lee syndrome, which was found in this North American registry. In the MELAS, they found these four overlapping gene mutations: MTTL1, POLG1, MTND3, and MTND5. So the overlap between MTL1 and POLG1 was between MELAS and chronic progressive external ophthalmoplegia, and MTND3 and MTND5 were related and associated with Leigh syndrome. This was the genetic pool out of which they, depending upon the frequently occurring gene mutations, they divided them into an ascending order. POLG1 was found to be present in 70 patients, followed by PDHA1 in 40 and OPA1 in 13, and rest followed. The diagnostic criteria for MELAS was initially proposed back in 1992. Later, it was revised in 2000, and I think so. It was 2012 when it was again revisited. So the criteria consists of two categories: Category A and Category B. Category A consists of clinical findings of stroke-like episodes, and Category B consists of evidence of mitochondrial dysfunction. In the Category A, headache with vomiting, seizures, hemiplegia, cortical blindness, and hemianopsia, acute focal lesions that are observed via brain imaging are the criteria. In Category B, the evidence of mitochondrial dysfunction with a high lactate level in plasma or CSF, or deficiency of mitochondrial related enzyme activity, mitochondrial abnormalities in the muscle biopsy, and definitive gene mutation related to MELAS are present. So definitive MELAS is said to be said when there are two items which are present in a patient from category A and two items from category B are present. Suspected MELAS is when there is one item from category A and two items from category B, a total of at least three items. The clinical manifestation, depending upon, because mitochondria is widely present in all the nucleated cells of the body, are in the nervous system: seizures, tremors, developmental delay, deafness, dementia, stroke, in less than 40 years of age, poor balance with peripheral nerve, and ataxia. In the eyes, there is drooping of the eyelids, acidosis, inability to move eyes from side to side, external ophthalmoplegia, blindness, retinitis pigmentosa, optic atrophy, and cataracts are commonly found. In the heart, you can have cardiomyopathy, conduction blocks. In the digestive tract, you can have acid reflux, vomiting, chronic diarrhea, intestinal obstruction. In the pancreas, you can have diabetes. In the liver, you can have liver failure and fatty liver disease. In the kidneys, you can have Fanconi syndrome, leading to loss of essential metabolites in the urine, nephrotic syndrome, um, and in the female reproductive issues, you can have female infertility, recurrent pregnancy loss. In the male reproductive system, you can have male infertility and azoospermia. Skeletal muscle abnormalities specifically are very common, causing muscle weakness, exercise intolerance, cramps, muscle protein presence in the urine, which is myoglobinuria. The neurological manifestation of stroke-like episodes, these are usually partially reversible, tend to present with aphasia, or can also occur with cortical visual loss, motor weakness, headaches, altered mental state, and seizures with the eventual progressive accumulation of neurological deficits. On the right side, this is a DWI sequence on the MRI, which is showing this temporoparietal DWI abnormality, which is present on the left side and in a patient. Seizures can occur, which can be in a focal or a generalized manner. Manifestation of stroke-like episodes are independent or they can co-occur. Imaging shows white matter lesions, cortical atrophy, corpus callosum agenesis or hypogenesis. This is an interesting image which is showing an abnormality in the right-sided occipital lobe, which you can see in the figure A. Figure B is showing a lactate peak on the functional MRI, which corresponds to an oxidative phosphorylation failure, and that causes lactate peak on this functional MRI. The figure C is of an EEG, where you can see from the right-sided occipital region, you can see there's a generalized spike and wave activity which is going on, which corresponds to a focal seizure in this patient. Overall manifestations of MELAS syndrome, the relative frequencies are shown in this table. Greater than 90%, you can have stroke-like episodes, dementia, epilepsy, lactic acidemia, ragged red fibers. In 70 to 89% people, there is hemiparesis, cortical visual loss, recurrent headaches, hearing impairments, muscle weakness. In 50 to 74% patients, there is a peripheral neuropathy, learning disability, memory impairment, recurrent vomiting, and short stature. In 25 to 49% of the people, there is basal ganglia calcification, myoclonus, ataxia, episodic altered consciousness, gait disturbance, depression, anxiety, psychotic disorders, and diabetes. In less than 25% of the people, there is optic atrophy, pigmentary retinopathy, progressive external ophthalmoplegia, motor developmental delay, cardiomyopathy, cardiac conduction abnormalities, nephropathy, and vitiligo. The main investigation in the laboratory investigations, creatinine kinase, lactate levels, pyruvate levels, myoglobin levels in the serum and urine can give clue during screening. CSF analysis has a non-specific higher protein level and also can have an increased lactate level, which is more sensitive. Molecular genetic studies, I'm going to come to them in a short bit, are particularly required for identifying these disorders. EEG can show either an encephalopathic picture or seizure focus. Neuroimaging can show basal ganglia calcifications. It can show these DWI changes. And the functional MRIs, you can have lactate peaks which are present. Uh, The neuroimaging of the affected area do not correspond to the classical vascular distribution. They are mainly asymmetric, involve predominantly the temporal, parietal, and occipital lobes, and can be restricted to cortical areas or involve subcortical white matter. The DWI changes are due to the cytotoxic edema, but there is also vasogenic edema which are found in these foci during stroke-like episodes. So they can have like these mixed signals on the DWI sequences with a true restricted diffusion versus an abnormal DWI abnormality. Uh, Conventionally, the MELAS disorder is considered present with normal angiograms, but there are reports where they have shown there has been some microvascular or macro angiopathy which can co-occur. MR spectroscopy shows decrease in N-acetyl aspartate signals and accumulation of lactate. These are some further pictures of the neuroimaging abnormality where you can see some basal ganglia calcifications, hypodensity on the CT scan on the right occipital region. We can see the DWI signal changes in the temporal lobe as well. And there is restricted diffusion pattern, but it does not correspond to any vascular territory. This is another image showing the same findings in another patient of basal ganglia calcifications. These higher foci in the left temporal lobe and a lactate peak. The muscle biopsy shows these pattern of ragged red fibers. This is an image showing different stains, the Gomerai stain, the NADH stain, and the cytochrome C oxidase stain. And the pointers are pointing out at the red ragged appearance of these muscle biopsy specimen in mitochondrial illnesses. Coming to the genetic test, the diagnosis of disease affecting the mitochondrial function is often challenging because of the dual genomic of the problem. There is a nuclear and a mitochondrial component. Multi-system manifestations and broad phenotypic heterogeneity encompassed by these conditions also pose a diagnostic challenge. For patients who present with a classical phenotype, initial testing should include appropriate mitochondrial DNA studies. This is a genetic screening test showing the mitochondrial DNA mutation at the loci A3243G, which is a point mutation, which is shown in this test, which is the most commonly occurring genetic mutation in MELAS. Principles of management in the MELAS evaluation of the multi-organ involvement is necessary. The management of complications and the things or the medications which need to be avoided are the main principles of any management strategy. So, management of complications include symptomatic management for the symptoms which the patient might be having. Some people say regular exercise can improve exercise capacity and lead to a better mitochondrial sort of capacity can cause some overcoming of these manifestations. Supplementation with L-arginine, citrulline, coenzyme Q10, creatinine, L-carnitine have been shown of some benefit in small trials. Potential treatment options which have shown some promising results include coenzyme Q10, L-arginine, B complex vitamins, vitamin C, vitamin E, levocarnitine in various combinations and doses. The concomitant administration of these different medications can be useful and has been beneficial to some patients of This is an interesting paper which showed the therapeutic regimen of L-arginine for MELAS, where they studied MELAS for 9 years prospectively, and what their conclusion was that the systemic administration of oral and intravenous L-arginine may be therapeutically beneficial and clinically useful for patients with MELAS. They didn't had any side effects in this cohort. However, the sample size was only 15 patients. Um, the important other finding was that the oral L-arginine decreased the incidence and severity of ictuses. Intravenous L-arginine improved the rates of four major symptoms, including headache, nausea, vomiting, impaired consciousness, and visual disturbance. This is another interesting research article, which was a case report studied in depth in siblings where L-arginine was found to have an effect on the cerebrovascular reactivity, perfusion, and neurovascular coupling in MELAS. Following the L-arginine administration, there was restoration of serum arginine in MELAS siblings and a trend towards increasing cerebrovascular reactivity in the frontal and corresponding decrease in occipital cortex. Cerebrovascular reactivity was unchanged globally. There was 29 to 37% reduction in baseline cerebral blood flow in patients following 6 weeks of L-arginine. Pre-treatment functional MRI activation in response to the visual cortical stimulus was markedly decreased in the same patient compared to controls. This is shown in the image on your right. That was also translated into a clinical beneficial role of L-arginine in these patients. There was another interesting study which was published in 2006 showing some beneficial effects of creatine, coenzyme Q10, lipoic acid in mitochondrial disorders, the combination therapy. Their sample size was small as well. They showed that there was almost 25 to 30% reduction in the serum lactate levels with the combination of these therapies. The other principle of management is to avoid medications which can have a deleterious effect on mitochondrial function. They include valproic acid, phenobarbital, carbamazepine, phenytoin, oxcarbazepine, ethosuximide, zonisamide, topiramate, gabapentin, vigabatrin, metformin. Dichloroacetate has shown to cause some peripheral nerve toxicity in these patients in a small trial. Aminoglycosides, linezolide, and alcohol mitochondrial toxicity is also related. Smoking should be avoided. In summary, MELAS syndrome is a frequent maternally inherited mitochondrial disorder. The cardinal features are stroke-like episodes, encephalopathy, and myopathy. Pathogenesis involves the energy deficiency, angiopathy, and nitric oxide deficiency. Management is largely symptomatic and should involve a multidisciplinary team approach. L-arginine, carnitine, and coenzyme Q10 are commonly used in treating MELAS. The M3243A gene mutations in the MTL1 gene occurs in 80% of the individuals with MELAS syndrome. So